Good morning. Welcome to PKD Connect. My name is Michelle Chanchel. I'm a professor of medicine at the University of Colorado, and I will be talking today about complications of ADPKD. My disclosures are mainly grant funding from the National Institute of Health, from Otsuka, Sanofi, Catman, and OPCO. I would like to start with a little bit of ADPKD epidemiology. PKD, as we know, is the most common hereditary kidney disease and is the fourth most common cause of end-stage kidney disease. Prevalence is difficult to estimate because a proportion of cases are asymptomatic and sometimes obviously undiagnosed. Recent observational study using administration claims and cross-sectional data estimates suggest that PKD prevalence is approximately 0.3 cases per 10,000 individuals, or an annual incidence of 0.6 per 10,000 individuals. Approximately, and this is probably the number that we all should keep in our mind, 140,000 patients currently are diagnosed with ADPKD in the US. The diagnosis in early adulthood is twice as likely among females, and the incidence is high in males among 65 years age group. Data from two large sequencing databases suggest a lifetime prevalence of 9.3 per 10,000 individuals. A couple of words about PKD pathophysiology. PKD results in the development and expansion of cysts within the kidney due to mutations in PKD1 or PKD2 genes in over 93% of the cases. The renal cysts develop in utero and continue to develop and enlarge throughout life. In the majority, clinical symptoms begin before renal insufficiency or kidney function decline and are observed during the first decades of life. And there is no question that, as we will be talking about the complications of PKD, PKD comes with hypertension, kidney stones, abdominal pain, hematuria, urinary tract infection, and other complications. What are the clinical manifestations? And this is a little bit of an introduction on what we're going to be talking regarding the complications of ADPKD. It's always good to divide these clinical manifestations as renal and extrarenal manifestations. The renal manifestations include, obviously, the multiple cysts in the kidney, which will result in acute pain, chronic pain, in hematuria, cyst infection, nephrolithiasis, hypertension, which we will talk a little bit more in detail. But there's no question that the most devastating outcome or complication of PKD is progressive decline of glomerular filtration rate, which will result in end-stage kidney disease, and all the complications of an end-stage kidney disease, including anemia, secondary hyperparathyroidism, metabolic bone disease, inadequate nutrition, increased cardiovascular risk. The extrarenal manifestations are obviously the liver cysts, pancreatic cysts, intracranial aneurysms, abdominal hernias, as well as cardiac valvular lesions, which we will also talk, because as you will see, the main cause of death in this patient population continues to be cardiovascular. How do we make the diagnosis of ADPKD? Patients at risk may be diagnosed before the onset of any symptoms, and usually the diagnosis is typically made by ultrasound. There's the presence of multiple bilateral kidney cysts and can detect cysts probably that are as large as 10 millimeters in diameter. High definition ultrasound can detect pretty much cysts of 2 to 3 millimeters in very experienced hands. CTs or MRI can also provide more data and be used for difficult diagnosis, monitoring, progression, and prognostication. Genetic testing may be necessary for atypical cases, especially those with a negative family history, and now with really the presence of genetic testing at the bedside, this has been used more commonly. And the screening at risk, but asymptomatic normotensive children at this point is not recommended. So what are the complications of PKD? This is a nice diagram that really puts hypertension. We have obviously agents for delaying or halting the progression of renal disease, which I mentioned is the most devastating complication of PKD. liver cyst, kidney stones, pain management, intracerebral aneurysms, UTI, cardiovascular continue to be all very important complications of ADPKD. So let's talk a little bit about hypertension. The prevalence at the time of diagnosis around 40 to 60%. Early onset up to 20% even in pediatric population. The lifetime risk is around 90%. The most preventable and treatable risk factor for progression is hypertension. And when we talk about hypertension, we need to talk about the choices of agents to treat it, which include the RAS blockers, meaning ACE inhibitors and angiotensin receptor blockers, diuretics, beta blockers, as well as calcium channel blockers. It's important to review a very important hypertension study that was done called the PKD trial, which was really two studies in one large clinical trial. It had a study A that included patients between the age of 15 to 49 with a baseline eGFR greater than 60, and a study B that included patients between the age of 18 to 65 with a baseline kidney function between 25 and 60. The outcomes, there were primary outcomes and secondary outcomes, which I will mention, but they were different. In study A, the hypothesis was that low blood pressure in that range, systolics pretty much of 110 to 70, diastolics of 75, versus a standard blood pressure of 120 over 80, will reduce the rate of disease progression measured by changing total kidney volume. And the hypothesis in study A and study B is that the dual blockade of RAS with ACE and ARB will reduce the rate of disease progression as compared with ACE therapy alone. So these are the endpoints. For the primary endpoint in study A was the percent change in total kidney volume. So these patients were the only patients that underwent assessment of total kidney volume by an MRI. And in study B, it was really time to death, end-stage kidney disease, or a 50% reduction in kidney function. There were numerous secondary endpoints. In study A was the slope of eGFR, urine albumin excretion, left ventricle mass index, renal blood flow. In study B was the slope of eGFR also. Again, these were patients with more advanced kidney disease. They also were evaluated for urine albumin excretion, and here, obviously, importantly, for all-cause and cardiovascular hospitalizations, as well as other PKD-related symptoms. So these were really kind of the main results of the study. The patients that were pretty much randomized to the intensive blood pressure, meaning the red line, had a really a slower progression in their total kidney volume compared to patients that were randomized to a more standard blood pressure arm, and this was statistically significant. However, there was really, when we look at changes of kidney function by eGFR, there was really no difference. And maybe one of the limitations of the study, despite being a 7-year study, but however, because PKD is a very slow progressive disease, unfortunately, they were not able to see any significant changes in kidney function. How about the, so this is obviously, I'm showing in this slide a summary of the primary endpoints in study E. That is kind of the annualized change of total kidney volume. And as I mentioned, if patients were randomized to the intensive blood pressure control, these patients actually had a slower progression, pretty much of their total kidney volume. However, not much difference regarding if patients were on an ACE inhibitor on its own or a combination of an ACE and ARB. And regarding time to death, end-stage kidney disease, and a 50% decline in kidney function, there was no question that the combination of therapy, correct, of ACE and ARB did not have any significant effect, and it was very similar to using lisinopril again. So again, it was not so much about the combination of a drug or a single agent. It was really more about blood pressure and the science. That's where it is today, that the important thing in these patients is really to treat their blood pressure to a systolic blood pressure of 120 or less. So the conclusions in study A is that the low blood pressure treatment in young, healthy, hypertensive PKD patients with RAS inhibition is well tolerated and safe, and results in a slower rate of total kidney volume growth over a 5-year, in reduced left ventricle mass index, urinary albumin excretion, as well as renal vascular resistance. In study B, again, these are the patients with more advanced kidney disease. The ACE inhibition monotherapy is safe and achieves excellent blood pressure control in most patients with PKD and CKD stage 1 to 3. And the addition of an angiotensin receptor blocker, although safe, under the conditions of the HAL PKD, does not really confer additional benefits. So there is no question that in this patient population, using one agent for the blockade of RAS would be enough. Again, really the advantages of managing blood pressure in this population intensively is that there is really a likelihood that the patients may develop lower kidney size, lower albuminuria, and have a lower left ventricle thickening as they progress through the disease course. Now, why is hypertension so important? Because we need to avoid another complication that happens in this patient population, which is left ventricle hypertrophy. Left ventricle hypertrophy, the consequences are inadequate blood supply, myocardial infarction, chronic ischemia and fibrosis, congestive heart failure, arrhythmia, as well as sudden death. It has been shown that left ventricle mass index in children and young adults is much higher, even when you look at very young kids between the age of 5 to 14, or even younger adults between the age of 15 to 25. There's no question that PKD patients will have much more significant LV left ventricle mass index than control patients. Interesting enough, LVH has been looked prevalence-wise in men and in women in patients with PKD and hypertension. That's the yellow bar. The red bar, patients with PKD and normal blood pressure and controls. And very interesting, even in patients with normal blood pressure, there is an increased prevalence of left ventricle hypertrophy in patients with polycystic kidney disease. So what is the pathogenesis of LVH? Obviously hypertension, and this is really very important and why we need to be aggressive in the management of blood pressure management in this patient population. Non-dipping blood pressure, meaning that the blood pressure does not drop during the night. And actually there's not a lot of studies in the PKD population, but some really suggest that the non-dippers have worse outcomes. Impaired capacity for exercise, induced vasodilation, obesity and insulin resistance, which is becoming this metabolic changes that we see in PKD, might not only have a cardiovascular impact, but also maybe an impact on progression of renal disease, as well as elevated levels of angiotensin II, aldosterone, endothelin, and other growth factors. Another cardiovascular complication is really the valvular complications of PKD, which is really the mitral valve prolapse in ADPKD. So as we all know, during late systole, the mitral valve leaflet cave back into the left atrium. The diagram really shows this leaflet lying behind an imaginary line drawn between the posterior aortic root and the atrioventricular groove. And that is really kind of, this kind of caving back of this valve is really what is known as the mitral valve prolapse. What is the clinical significance of mitral valve prolapse? So first of all, is a thickening of the leaflet to more than 5 millimeters, and this is diagnosed by echocardiogram. The mitral valve prolapse has been associated with atypical chest pains and palpitations. It may be more complicated by infective endocarditis, which is a very serious complications, as well as it can progress to mitral regurgitation. Mitral valve replacement at times, obviously, if patients develop endocarditis or mitral regurgitation, may be required. Echocardiographic studies in the 80s and 90s from our center and other centers reported approximately a 25% prevalence of mitral valve prolapse in ADPKD versus 10% in the controls. And in children with PKD also have mitral valve prolapse more often than unaffected family members, approximately 12 versus 3% in a study from the Colorado group. And this is really now an old publication that really describes kind of the clinical cardiovascular characteristics of patients with PKD. So this is a study comparing, so they included 109 patients with PKD. Most of these patients had PKD type 1. And they also look at 73 unaffected family members and 73 healthy controls. The mean age was around 44. This is actually the range. And only significant mitral regurgitation grade 2 and 3 was reported here. and there's no question, it was more common in patients really with PKD than in the unaffected family members and obviously the controls. Systolic blood pressure with increasing age and decreasing renal function were also related with mitral regurgitation and left ventricle hypertrophy in this study. So again, much higher prevalence of mitral valve prolapse in the PKD population, much higher prevalence of mitral regurgitation in patients with PKD. So let's talk about kidney disease progression. As I mentioned, this has been very well studied. And there's no question in the social science world, when you get patients with PKD, they will all agree that this is really the complication they are scared the most. And rightly so, that is kidney function decline. This is a progressive disease. And we know that as the kidneys become larger, there will be a decline in kidney function, progression to CKD, and unfortunately ending in end-stage kidney disease, going through the routine stages of CKD, stage 2, 3, 4, and obviously 5. And during the course is where we have kind of the development of complications like hematuria, stones, and infections. So we know that, that patients that as they age, and obviously depending on their mutation, their total kidney volume will be larger. There's a wide distribution in total kidney volume. It differs between the PKD1 and the PKD mutation. We all know that the PKD mutation is more severe and more aggressive, but we know that the larger the total kidney volume, the more aggressive the disease, and more likely is the patient to progress to CKD and end-stage kidney disease. There's been many studies looking at the relationship between kidney function and renal volume, and it's a very, very strong inverse correlation where patients that have pretty much a much higher total kidney volume are going to have a much lower GFR. So we know that patients with a larger total kidney volume will have more progressive kidney function decline. And this is why the FDA approved. This is the only drug that has been really approved for the management of PKD, and this is Tolvaptan, which is really binds with a high affinity to the V2 receptor. And I'll show some of the TEMPO trials or some of the Tolvaptan program that pretty much have shown some reduction on the annual rate of progression of kidney disease of approximately 31%. Again, because it really blocks V2 receptor, blocks effects of vasopressin. And as I talk in the pathophysiology slide, obviously a hormone that is key in the progression of making total kidney volume worse or larger, and obviously related to kidney function decline. So these are the two main studies that I would like to talk about. This is the TEMPO and the REPRISE. You can see a very large number of patients, 1,500, 1,300 patients, good randomization. These are recent studies. The age in TEMPO and the age in REPRISE. I think the most important thing to keep in mind is that in TEMPO, they included patients with a GFR greater than 60, and in REPRISE, pretty much the GFR was below 65. So they had really patients with stage 3A and patients with stage 3B. And that there was a total kidney volume requirement in TEMPO that was not present in REPRISE. TEMPO was longer at 3 years than REPRISE, and the primary outcome really in TEMPO was change in total kidney volume, and in REPRISE was change in kidney function. And very nicely shown here in TEMPO is that the patients that were randomized to Tolvaptan obviously had a much slower progression of total kidney volume, and you can see pretty much the yearly percent. We're talking about 5.5 for the placebo versus 2.8 on the Tolvaptan. And in REPRISE, remember that these patients had more advanced kidney disease, correct? They were below a GFR of 60, and therefore these patients who were randomized to Tolvaptan had a slower progression of kidney function decline compared to the placebo. So what is the risk-benefit ratio? And I'm spending some time on this just because this is, again, one of the few drugs that we have that really, or the only one that has been really FDA approved. A lot of research being done in other areas to try to determine other molecules that could slow down progression of renal disease. But at this point, Tolvaptan is really the only one that has been approved by the FDA. So the benefits clearly slows kidney growth. It slows EGFR decline. It may delay the need for kidney replacement, although this has not been solidly, has not really been proven. It may reduce pain, hematuria, stones, and other urinary tract infection events, and may have a reduction in blood pressure. What are the harms? And really more than harms are really kind of complications of the therapy. Patients will have polyuria, pollakiuria, and nocturia. This is really a big issue with the drug. As they become more polyuric, they're thirsty, they're fatigued, they may have some uric acid elevations. We have been associated with worse progression of renal disease in PKD. This one has been really a very scary complication for patients, that is the transaminase elevations and the risk of severe hepatocellular toxicity, which requires frequent monitoring of liver function and possible drug interaction. And there's no question the drug is not cheap, and it's a financial burden for patients who really don't have adequate insurance. So moving to other complications, kidney stones. So occurs in 20% of PKD patients, mostly uric acid stones or mixed uric acid with calcium oxalate. Hypocitraturia is seen in almost 70% of these stone formers. The treatment is drink, and drink water, 3+ liters a day. Very important low salt diet. Alkalinization of the urine, which is very difficult to do, but we have to try our best. Obviously citrate supplements, and when needed, lithotripsy. And kidney stone has become really a major focus in the care of patients with PKD. As we know from the CKD non-PKD literature, nephrolitized kidney stone disease has been shown to really be a very important risk factor in progression of renal disease. And actually there are some ongoing studies to see what would be the effect of kidney stones on progression of patients with PKD. How about infections? Well, includes cystitis, pyelo, and cyst infections. They all obviously, when you're facing a patient with infections, they all need urine cultures. And there is no question that the duration of treatment should be much longer than any other type of kidney infection. I cannot repeat this enough, but choosing the right antibiotic is key. We need antibiotics that can penetrate inside the cyst, because that's really where the infection gets localized, and this is why patients can get very sick. So there is no question that quinolones, Bactrim, and vancomycin are excellent choices. Beta-lactams are not so great in the penetration of the wall of the cyst. So there's no question that keeping in mind quinolones as the main way of treatment is key for this patient population. So how about pain? Pain, there's no question, a lot has been written on pain in patients with PKD. We know that this chronic kidney pain, chronic discomfort is really a major issue. It correlates very nicely with kidney size and cyst. If it can be really debilitating, affecting social and job performance. Yes, the pain management, you can use obviously acetaminophen, and it can be the whole spectrum all the way to narcotics. But we always have to be very careful with the risk of dependence. The cyst drainage is a possibility, and only if there's a few predominant cysts, and that we think that cyst may be causing the pain, and it can be accessible by percutaneous drainage with especially kind of large cysts. De-roofing will be a surgical technique. Was commonly performed more in the 80s and 90s. It's not so much in vogue nowadays. Surgeons don't like to do it, and many because really the results have been somewhat disappointing. The renal sympathetic denervation is invasive and really should be considered in very severe cases. How about liver cysts? Actually, the liver cyst is one of the #1 extrarenal, or the most common extrarenal manifestation. 75 to 90% of PKDs will have at least one liver cyst. So if you're going to do an abdominal ultrasound and the patient has polycystic kidney disease, very much you are going to have a very high likelihood of observing liver cysts in that patient. The cysts, interesting enough, do not cause liver failure. They may cause mechanical compression, malnutrition, and rupture, as well as infection issues. The risk factors for large liver cysts, unfortunately, are female patients, exposure to sex hormones. Liver transplant is difficult to justify because really these patients don't meet MEL scores. But however, if we have a large liver impeding into stomach and causing early satiety and malnutrition and discomfort and pain, they might be indication for a liver transplant. Somatostatin analogs can reduce liver size by 5% over 6 months, but at the same time, there is a risk of diabetes with this molecule. And at times, obviously, partial hepatectomy or cyst deroofing surgery can alleviate symptoms, but we have to remember that this liver regrows. So very severe cases, really, the recommendation is mainly liver transplantation. How about intracranial aneurysm? It's a very devastating and very scary complication, rightly so, for our patient population. It's present to 10 to 12% of all screened PKD patients. 75% are in the anterior circulation. So this intracranial aneurysm or doliectasia is an elongation dilatation without aneurysm, correct? So that is kind of another presentation of this intracranial aneurysm. Is this more of an elongation and a dilatation of the vessel, and not necessarily an aneurysm, and that happens in 5% of the cases. The screening should be offered if patient is symptomatic, for sure, if there is a positive family history of a catastrophic event or a stroke, high-risk jobs, and the classical is airline pilots or obviously pre-transplant or surgery. You can do the screening with MRI. Without gadolinium is really works wonderful. And if the first screening of the MRI is negative, there's no need to repeat for another 5 to 10 years. And there's no question that in this patient population that have aneurysm, we have to be very careful about their blood pressure, smoking habit, heavy alcohol consumption. This needs to be avoided, as well as stimulant medications, illicit drugs, as well as excessive straining or Valsalva maneuvers. There's no question that the surgical clipping is recommended if the size of this aneurysm is above 7 millimeters. I was mentioning about the causes of death in ADPKD. So really there hasn't been that much written in this topic, believe it or not. But before 1975, this is a very old paper, but it's really a classical paper in death and complications of PKD. Was done out of our center in Colorado, looking at death before 1975 and after 1975. And you really can see that the major cause of death is cardiac disease, obviously infections. Obviously, uremia was more of 1975, just because obviously it was more difficult to get access to dialysis. But you can see there is neurological events, pulmonary emboli, non-renal cell carcinoma. But again, I think the message here of this slide is really kind of the cardiovascular complications or the cardiac disease of this patient population. Now here is comparing ESRD versus non-ESRD. Again, cardiac disease, very high. There's no question infections is very high in the ESRD PKD population. And interesting enough, the neurological events were very high in the non-ESRD CKD patient population regarding causes of death. I think, again, cardiovascular is the #1 causes of death in ADPKD. This is a more recent view at this problem. This was just published now almost 10 years ago in NDT, looking at different time periods and almost repeating a little bit the previous study. And again, cardiovascular disease, and you can see kind of the time periods between 93 to 2000, and then after 2000, although there was a decrease in cardiovascular disease, still cardiovascular and infection continue to be the #1 causes of death. And then this is, again, the ESRD patient population, looking also that cardiovascular disease regarding the time period, even before 2000 or after 2000, cardiovascular disease were the most important causes of death. I want to talk about some interventions. I know the talk should be concentrated on complications, but this is just such a hot topic in PKD. A lot of research is being done here in our center that I really wanted to mention a couple of slides about it. We've classically talked about low protein intake and low salt diet and high water intake, but there's no question that intermittent fasting as well as keto diets may have a significant impact in the progression of renal disease. And I think it's important to talk about other interventions other than Tolvaptan, just because progression of disease, progression to CKD and end-stage kidney disease is such a devastating complication. So the low protein diet, really the data came from the famous MDRD study. So this was a subgroup analysis of PKD participants in the MDRD study. And you can see pretty much that patients were obviously randomized to a usual MAP versus a low MAP. And there's no question that the patients that had or were pretty much also randomized to a low protein diet had kind of a decline in the progression of renal disease. The problem is that the low protein diet is extremely hard to keep and probably unrealistic to really extrapolate this to or to generalize to the population. There's been a lot of talk about salt. This was a post-hoc analysis from the whole PKD study where they had urines, they had urine sodium excretion, and actually they measured the association between urine sodium excretion as well as changes in total kidney volume and changes pretty much in eGFR and progression. And it was very clear that increased urine sodium excretion, which correlates with increased sodium intake, will have pretty much a much higher correlation, a tighter correlation with larger total kidney volume and with progressive kidney disease. We've talked a lot about water. There's no question that the high water intake can slow cyst growth by suppressing this famous cyclic AMP. This was a small study, 34 patients randomized, 30 completed. They were followed up for a year. The primary endpoint was change in total kidney volume as well as eGFR. They divide into regular as well as high water, and you can see pretty much kind of the volume pretty much in the regular and high water. And you can see pretty much that really the changes were borderline significant. There's no question that the high water intake group in approximately 17 patients did show a significant change in eGFR, but really the changes were not that really that significant. Nonetheless, we continue to recommend our patients to drink, to have high water intake with the idea that there is going to be some suppression of vasopressin and potential some benefit regarding progression of renal disease. So you can see that pretty much the p-values, correct, they were all close, and how much of this is because of sample size or because really of the intervention, and that really continues to be a question. There's no question that when you look at the hormonal changes, the high water intake had some significant changes on hormonal changes. Regarding caffeine, there's no question that there are some lab models, animal models, that the increased intake of caffeine increased cyclic AMP accumulation and activated transepithelial fluid secretion in ADPKD. The human studies really have not shown any effect regarding caffeine, regarding GFR, as well as total kidney volume. The smoking idea actually came pretty much from Colorado, where murine models were shown that nicotine increased ADH levels and cyst growth. And in human studies, there's no question, and this has been really shown in PKD patients, that the higher package year usage of tobacco is associated with higher microalbuminuria and proteinuria, and pretty much with an increased odds of obviously of progression, especially in other causes of kidney disease. Obesity, and this is why I think this is the new kid on the block. I think that the relationship between an abnormal metabolic pathway and PKD is very strong. This is data from our center that's showing that higher BMI was associated with a greater change of total kidney volume. And there's no question that patients who are obese or overweight have a much higher odds of progression in total kidney volume or kidney function decline when they compare to patients who are normal weight. Ketogenic diets in animals have had a significant effect, as well as time-restricted fasting in the progression of renal disease. Ongoing human studies will really shed some light if really some type of dietary interventions may have an effect on progression of renal disease in PKD. And again, we think that a lot of these metabolic pathways are really decreasing, working through the mTOR pathway. And honestly, we really don't know exactly how they actually work and how the effect could be so profound, at least on the animal models that have been published. Nonetheless, more studies are ongoing to really determine if the dietary interventions are effective in human disease and try to understand a little bit more about the mechanism. So in conclusion, I would like to say that cardiovascular abnormalities remain the most common cause of premature death in ADPKD. These abnormalities involve the heart, muscle, the valves, and major arteries. We talked much about vascular dysfunction, but this is really a true complication of patients with PKD. Hypertension happens in 60% of these patients with PKD before renal function has become impaired. Early and effective treatment of hypertension is very important to decrease the morbidity and the mortality of this patient population. And there's no question that there are direct consequences of abnormal polycystic signaling that will affect cyst proliferation and will be involved in progression of renal disease, and therefore involved in a lot of the complications that we've talked about, like cyst infection, urinary tract infections, as well as nephrolithiasis. I'll stop here. I would like to thank the PKD Foundation for this invitation and for allowing me to talk to this audience on complications of PKD. Thank you.